Assistant Chief of the Lehigh Valley Cancer Institute. I'm a medical oncologist. I'm trained at University of Pittsburgh 34 years ago, and I was so lucky to work with two giants in immunotherapy. This is back in 1987, where we didn't have all the great medicines that we have now. But John Perkwood came from Yale to the University of Pittsburgh, and Mark Ernstoff also came with them. John specialized in melanoma, and Mark specialized in kidney cancer. And the Mellon family had just given the Pittsburgh, they created the Pittsburgh Cancer Institute at that time. And as a fellow, I went there to study to be a leukemia doctor, because Pittsburgh was a great leukemia program also, but I got so swept up with the excitement of the theories, and back then it was just theories, because in the old days all we had were crude immunotherapy medicines like interferon, interleukin-2, which had a lot of side effects, but did cure some patients of advanced melanoma, did cure some patients of stage 3 melanomas, but they had the theories. And then next week, now Dr. Kirkwood is just retired as he's still emeritus professor at University of Pittsburgh, but Mark Ernstoff is now director of the immunotherapy branch at the National Cancer Institute. He was asked to serve as the head for the country. And next Thursday, we're having our kidney cancer survivor celebration. Mark is actually coming here to the Lehigh Valley to give a 30-minute talk. So both John and Mark, I give a lot of credit to. And I've been fortunate to have my first 14 years. I had a great practice at Geisinger and Danville, where I trained and where my wife is from. And then one of the best things that happened to me was a chance to move here 19 years ago to be head of research and to really establish a melanoma and kidney cancer research program. And along the way, we've developed an amazing team of colleagues. So tonight, right now in our melanoma program, we have some of the earliest successes in curing stage 4 melanoma, initially with high-dose interleukin-2. So just to give you an example, this is the first 10 years, 2004 to 2013. We treated 50 patients with stage 4 melanoma with high-dose interleukin-2, and we cured 5, which at that time was really good. And sitting right here, Linda, can you stand up and just wave? Glenn is our second longest survivor of stage 4 melanoma. Just preceding him is a gentleman who's now retired in Nashville, Tennessee, that the nurses called Iron Man, because he was 69 and took high-dose IL-2. But Lynn was a farmer from Mechanicsburg. You would never know what his age is, how great he's doing. He's 16 years out now. And it really showed that the immune system can cure advanced melanoma. But fast forward to 2013, when the new medicines, all developed, and they were in clinical trials. And I want to recognize, our amazing team that's here. Morgan, can you just stand up? She's passed for this. As our director of clinical trials 10 years ago, I said we were the Jamaican bobsled team. We competed to be one of the 10 sites in the U.S. for the first testing of phase 2 nivolumab and ipilimumab, and we got some of our first 2 out of 4 patients. Richard is here, who was in that original group, who is now over 10 years out. Since then, through the development of immunotherapy drugs like ipi, nivolumab, Keytruda, pembrolizumab, we have now 50 patients that are 3 to 18 years out from their last treatment for stage 4 melanoma. And everything we're seeing at Sloan and here is that once you're 3 years out with the modern medicines, most likely patients will clear. We see very few recurrences. And so out of our 50 stage 4 survivors, 30 are here celebrating tonight, and I'd like to just truly at every table we have that. So, and you're going to see, you're going to get to hear from amazing teams, starting with Cynthia Vardis, and I don't know if Josh Levin is here from, oh, is he in bed or there's Josh? So they're our front line of defense, diagnosis, early detection. We have wonderful partnership with Advanced Dermatology right across the street. When I first moved here, Tanya Ermolovich was a friend, and they supported our program right from the get-go. And we've seen when we benchmark against national standards, our patients are being in the Lehigh Valley are being diagnosed earlier than national standards. So they, and they're so collaborative, and we're very fortunate to have them. My colleague, Aaron Blackman, you're going to hear from Aaron. He's our main surgical oncologist who came here as really pioneered a lot of things, including phenomenal teamwork and surgical treatment. And we have our melanoma navigators. Angela, can you stand up? And then Virginie, our not so new navigator. Virginie, can you just stand up to her? Angela's briefly working from home, or not even home, in that building, and we're going to get her back. And Regine joining us from Dublin, was so lucky to have her. And then Lauren is here. Lauren, she had to go back. Okay, she's been, patients call her sunshine. She's such a big part of the team. And so we have an amazing program. So I'm gonna, and I think one of the things that we're so proud of, our stage 2 and 3 melanoma survivorship is very significant. We have quite a few survivors here that are, early stage. And in stage 3, we look at 2011 to 2020. We have about 180 patients that were treated for stage 3. And our survivorship is about 20-25% higher than national, according to the SEER database. So we're actually we have a summer student, Aiden Johnson, who's at Penn State. He's a pre-vet major. He's going to be working with us and do a whole database. We're going to publish why, because it's this, the team that's in this room. It's all, we started celebrating in 2014. I think this socializing and celebration has really helped us. It's kept our team together. And so, we're just here to celebrate everything. We couldn't have asked for a better day. We haven't had a live celebration since 2019. And how nice it is, to be in this beautiful environment. And I'm going to introduce our speakers. So our first speaker is Dr. Cynthia Vardis. Cynthia is an amazing dermatologist at Advanced Dermatology. She's a Mohs surgeon as well. She gave a amazing talk last year virtually for us about skin health, and that this is melanoma like this. Thank you, Cynthia. Hi, everyone.
All right. Well, I see some familiar faces in the audience. Thank you so much for having me. It really is a privilege and an honor to be here in front of you all. One, that we're live and I don't have to be behind my computer giving this lecture. And two, I'm not covered up in a mask and gown and goggles, so some of you may not even recognize me, because it's probably been 3 or 4 years since you've seen me without full protective gear. But I really enjoyed giving this talk last year, and hopefully there's some information that you can take away from it, especially the fact that I can give this talk, because as Dr. Nair mentioned, we have so many survivors in this room. This is such a wonderful thing in my career, just to see the advancements and changes that have been made in this disease. I'm just so happy that you're all here and that your family members are here to help celebrate this amazing accomplishment and achievement with you. So thank you so much, everyone, for being here, and let me go over some information on detecting and preventing skin cancer. I'm trying to stick within my time limit here, because I could talk about this topic all day long, so, as I often do. All right, so let's get started. All right, so as some of you in this room already know, 1 in 5 Americans will develop skin cancer in the course of their lifetime. So if you look to your left or look to your right, you're probably going to see someone, obviously, who has already had a skin cancer. And if you don't know anyone that hasn't had one, they'll probably find someone that does. So what can we do to help identify folks with skin cancers and get them treated, and then get them through into the survival phase as quickly as possible? So let's see what we can do to help detect and prevent skin cancer. All right, so research estimates that there are about 3 million Americans a year that are living with non-melanoma skin cancer, and more than 1 million Americans are living with melanoma. I'm going to talk about the 3 main types of skin cancer to be on the lookout for. Number 1 is basal cell carcinoma. Number 2 is squamous cell carcinoma. And of course, number 3, melanoma. All of these diseases are treatable and curable when detected early, so that's the key, early detection. The longer these things fester, well, the more likely they are to spread into other organs and cause other trouble. So how can we detect them early? All right, so basal cell carcinoma. This is our most common skin cancer. Now, when detected early, I often tell folks to kind of forget about the C word that's associated with cancer and think about it more like the C word that's associated with the cavity. So, basal cell carcinomas are generally not the things that are going to need immunotherapy, chemotherapy, radiation, PET scans, CAT scans. They are going to need biopsies to make sure we've got the right diagnosis, and then they're going to need some type of treatment. That may be something like a little scraping, it might mean a little cream, or it could mean a surgery where we cut it out and check it under the microscope, make sure we have it all out, stitch you up, and send you on your way. If you don't treat them or catch them early, then you can start getting into a little bit more trouble. But most of the time, these are for the most part, if you can say a harmless cancer, it's a harmless cancer. But if you fail to treat it, it can get to the point where it's eating away at pretty important structures. So they most often appear on sun-exposed areas such as the face, especially the nose, the ears, the scalp, for those of us that don't have as much hair as we used to, but also in the chest, in the back, and the lower legs. They'll present with a flesh color, what we call pearly bump. It can be a little bit pinkish in color. I often hear people describe it as a pimple that just won't go away. They'll also say that it starts and looks like it's going away and then it comes back again. And it's going away and it comes back again. So my general rule of thumb for folks is if you have a bump that doesn't look like your other bumps, and it looks like a pimple that doesn't quite behave like one, and it keeps coming and going, then it's time to get it checked out. They're also more prone to trauma, so you'll be toweling off your face and you'll notice a little tinge of blood, and that's something that we should look at. Now, I mentioned that they can be pretty destructive on where they're growing, so they're not going to, like I said, get into other organs, get into your lymph nodes, but if you leave them go long enough, they can do some pretty good damage to the area where they're growing. So I have seen them eat away at noses, I've seen them eat away at ears, I've seen them eat away at the eyes. So the sooner we get these things diagnosed and treated, the better off we're going to be. So those are your basal cells, okay? Pretty common. You see them a lot. You get it diagnosed and treated early, and you forget about it. All right, next up, squamous cell carcinomas. All right, so these are the second most common type of skin cancers. They tend also to form on the sun-exposed skin, like the ears, again, the face, the neck, the arms, the chest, and the back. These can look a little bit different. I think you can see on the picture there. Sometimes they form as these kind of red, friable little nodules. They tend to be more painful, where basal cells, on the other hand, tend to maybe itch or be a little bit painful. Squamous cells really tend to hurt. They will sometimes be itchy, but I find that they're more scaly, they're more red, and they're more tender. So they'll look like a red fur bump, or they might just look like a scaly patch, almost like a rash. And again, they'll go through that process of healing and then heal. But a lot of folks do think it's a rash. Again, most rashes go away. As one of my mentors used to say, 90% of rashes go away. It's the 10% that don't that you actually have to think about. So when a rash you have is not going away, then it's time to get it looked at. Now, the issue with squamous cell carcinomas is they don't behave quite like melanomas, but they can start to take on some of those features of melanomas where they lose their loyalty to the skin, and they can get into lymph nodes, they can get into other organs. When you get these things identified early, far less chance of that happening. But if you let it fester, you let it go, it can really start to cause trouble where you might need the help of Dr. Black or Dr. Nair. So you get these things treated early, far less chance of needing to see my lovely, wonderful colleagues, but the less time you spend with them, overall, the happier. Social settings are great. I love seeing you guys in social settings. This is amazing, but in the office setting, let's try to avoid that if we can. All right, so those are our squamous cell carcinomas. Now, The other thing we have are the melanomas. So as many of you know, these are our most serious form of skin cancer. They tend to arrive completely out of nowhere. So completely normal skin, and all of a sudden you get this weird looking bump or something doesn't seem right. But about a third of them can arise in a pre-existing mole. And they typically appear on the upper back, the torso, the leg, the lower legs, and the head and neck area. And we estimate there are about 100,000 of invasive melanomas arising per year in the American population. Sorry. And let me just go on to say who gets melanoma. So you kind of look around, people that may look like you, but melanoma does not discriminate. So unlike our basal cell skin cancers and our squamous cell skin cancers, that typically tends to affect folks at higher risk, Caucasian individuals, people with red hair, blonde hair, green eyes, blue eyes, sunburns, the past, working outside for their jobs. Those are all the things that put you at higher risk for basal cell and squamous cells. And yes, they put you at higher risk for melanomas as well. But melanomas really can arise in anyone, anywhere, at any time. Unlike my basal cells and squamous cells, which tend to gravitate towards folks that have had a few more birthdays under their belts, melanoma can arise at any age. In fact, it's one of the most common cancers in young adults and adolescents, so roughly 15 to 29-year-olds. That's one of the most common cancers that those folks will get. So you might see all ages in this room here tonight. Yes, you can be affected by this disease at any age. You're also at higher risk the more moles you have. So if you have about 50 or greater moles, we know that is an increased risk. If you have a large mole, a large congenital nevus, that puts you at higher risk. So there's a bunch of factors that also you may want to be thinking about when you're thinking about your risk. Of course, family members, so having a direct family member with a history of melanoma puts you at a higher risk for melanoma. So for all of our survivors out there, very important that your direct family members, so your sibling, your children, your cousins, your aunts, your uncles, your parents, know that you have this condition or this disease and that they get screened appropriately. So they should be seeing their dermatologist at least once a year for a full body skin check. That can really help save their life in the future. The other thing that we're learning more about, and I know I've seen some of the genetic counselors around and the information we have, certain genetic mutations have been associated not only with melanoma, but with other conditions like pancreatic cancer, breast cancer, and thyroid cancer. So if you have a family history of these cancers, it's important to be screened for melanoma as well. All right, so some of you are very, very familiar with this topic. Others of you may not be, so let's go over it. What does melanoma look like? Well, we typically describe it using the A, B, C, D, E's. So we talk about asymmetry. So if you have a mole or a bump that just doesn't look like it's a mirror image of itself, you fold it on each other and one side looks really different than the other, that could be a sign that something is going on. It may not be, but it should get checked out. Border irregularities. So if you see something as a very jagged border, not that smooth, nice edge, yeah, it could be something that we should look at. Colors. So if you have a mole that's starting to change colors or have multiple different colors, red, white, blue, just something that's not a nice, uniform, pretty color that it usually is, let's get it checked out. Diameter. So the larger moles, those are the ones that we tend to get a little bit more excited about. So if something is starting to get a little bit bigger, we generally say greater than the size of an eraser, then we want to get it checked out. Here's the big one that I go by often, evolving. So if there's a mole that's changing, let's look at it. It may be nothing, it may be completely fine. It might have just been that you scratched it with your razor or your fingernail that day. But if you see something that's changing, let's take a look at it. So that's the biggest one that I use because we all can look at our spots and one day it looks a little bit awkward, maybe a little asymmetric, and everyone starts to come to with these seborrheic keratoses. A lot of you in the room are familiar with these. These are really scary looking growths, but they're basically benign, harmless, wart-like growths that we all get as we get more birthdays under our belt, but they can look really scary. So if you have one of those spots and you're worried about it, definitely let us take a look at it. It can really meet all these criteria, but it ends up being harmless. It's very confusing. It can be very hard to sort it out. So see your dermatologist. We can help you out and guide you through what should be biopsy and what shouldn't be. And I was just mentioning at our table that I often go by what the patient is telling me. I can say all day long, that's fine, it looks fine, it looks fine, and you can say to me, no, this has changed, I want it up. I know that you guys know your bodies better than anyone else in this room. So if you have a spot that you just do not feel comfortable with and you want it gone, you make sure that your dermatologist or your primary care doctor takes care of it. So at the end of the day, you know your bodies better than anyone else in this room, and I try to listen to the patients as best as I can, and I teach my residents that too. You know your spots far better than any of your doctors or nurses or healthcare providers will ever know your spots. So make sure you let us hear about it if something's changing. All right. So how else can we help prevent skin cancers, or at least identify them and get them biopsied and treated in a timely fashion? Well, a lot of you are here today with a partner of some sort, maybe a spouse, maybe a loved one, a sibling, a child. So screen the ones you love. There's been data to show that those who have a partner of some sort do better. Their spots are detected earlier, they get treated faster, they have a higher survival rate. So that is the best way to get these things taken care of, whether it's a basal cell, squamous cell, or melanoma, is screen your loved ones. So what we generally say is once a month, give yourself a look over, and that includes all your nooks and crannies. So it might be a little bit awkward, and you might not feel all that comfortable finding someone, but do the best that you can. Use a couple different mirrors, bend over the best that you can. But once a month, pick a day, maybe the first of the month, maybe on your birthday date. For me, it's the 16th. Got a birthday coming up today. But look your body over. Look in all the creases. Make sure you don't see any spots that look suspicious, like we talked about a few moments ago. So you can get a full-length mirror, check yourself out, look at all the under surfaces the best that you can. Be sure you look at the bottom of your feet. We know that what we call apical lentiginous melanomas have a worse outcome. And we used to think there was something special about those moles, that they're on your palms and soles, that's why they go bad. It's probably got nothing to do with the fact that your palms or your soles, it's probably got more like something to do that you just don't know that it's there. How many people have checked the bottoms of their feet or in between their toes closely recently? Probably not that many. So if something is going on there and it goes bad, it might be a while before you figure it out. So we definitely want you to do the best that you can to look at your palms, look at your soles, look in between the fingers, in between the toes. And again, you'll see in the figure 4 there, using the mirrors to kind of check those areas that you can't see. Figure 5, same thing, doing the best you can. Now, some people will say, well, how does my family member know what to look for? That goes back to that evolving part, or the ugly duckling sign. So if you have a family member, they can come in with you to the dermatologist's office, we look you over, everything looks good, they can kind of get a baseline. And then when they're helping you with those skin checks, if they see something that just sticks out, that doesn't seem quite right, we're not asking your family member to make a diagnosis. We're just asking your family member to say, hey, I don't like that one, let's make your appointment. So that's what I can say about that. I'm not asking all of you to become skin experts or Dr. Nair experts. I'm just asking you to have your family member look you over and say, that doesn't look right, let's have it checked. And I love when my patients come in with circles on them or stars next to their spots. It's great, it makes me so happy. Like, okay, let's check that. And then I can say, this is okay, you have a baseline. And the other part too, now with all our smartphones and our amazing cameras, you can take pictures of spots and then you can monitor it. And if you see some changes there, you just go back to last month's picture and it's there, and like, yeah, that looks different, then come on in, let's take a look at it. So there's so much that we can do at home that can really, really make a big, big difference. Now, if you've been diagnosed with a melanoma or squamous cell carcinoma, I also recommend that you check your lymph nodes. So that can be a little bit trickier, but typically under the arms, around the head and neck area, in the groin, and then certainly when you're showering or soaping up or drying off, if you feel a lump or bump in that area, and you've already been diagnosed with one of these skin cancers, you definitely want to bring it to Dr. Nair's attention, to our attention. That might be a sign that a cancer has gotten into the lymph nodes, in which case we want to get it identified and detected. Swollen lymph nodes can happen for any number of reasons, but if you have that history, again, if you're feeling that swollen gland, don't wait another 2 months for your appointment. Let us know about it. All right, so prevention. Okay, so what can we do to protect ourselves or hopefully getting these skin cancers or getting more of these skin cancers? We do know that once you've had any skin cancer, you are at risk for developing any of the other types of skin cancer. So, my melanoma folks in this room, I'm so happy you're here, but there is a risk that you might see me for one of your basal cells or squamous cells in the future. One of the areas of interest that I have is especially folks who have been treated with immunotherapy. I'm curious to see what kind of protection that might lead to in the future, so that maybe you won't be developing these basal cells and squamous cells. I've just been talking about that at my table. So I'm hoping that with all the treatments you've had for your melanoma, that maybe you won't have to see us very often for basal cells or squamous cells. But until we get more data on that, we still want to keep an eye on you. And of course, all your loved ones too, they're at risk for the melanoma or the basal cells and squamous cells. So how do we keep you out of trouble? Well, seeking shade is super important. So trying to avoid the high, heavy sun, 10 to 4, 10 to 2, being under shade structures. Wearing protective clothing, I mean, that's a huge, easy thing to do. Not only have there been great advances in immunotherapy, but there's also been great advances in sun protective clothing. I have a lot of folks who are resistant to wearing long sleeves or hats or pants. Oh, it's too hot, I don't like how it makes me feel. The fabrics have gotten so good. I'm a hiker, I'm an athlete, I'm out in the sun a lot. You will rarely see me not in full garb. The fabrics are so good at wicking the sweat, keeping you cool, keeping you dry, and you don't have to put on all the greasy sunscreen. So I'm a big advocate of wearing sun protective clothing. You put it on, you do your thing, you enjoy your day. That includes hats, that includes sunglasses, that includes long sleeve types of swing rash guards or outside gardening. They make these beautiful sleeves that you can put on, the pants. So love, love, love the sun protective clothing. And then the other one is generously applying your sunscreen. So we'll go over the sunscreen specific tidbits here. I get so many questions about that, so let's jump into the sunscreen. Okay, so sunscreen, so many questions. One of the questions that came up was what's better, a chemical-based sunscreen, like ones that have octinoxate in it, or all these other long words, or zinc oxide, which is typically our physical blocker. So, in an ideal world, I would love for all of you to use a physical blocker, one that contains zinc oxide, which you think about with the lifeguards back, using it all over their noses, or diaper cream, that's a high concentration of zinc oxide. Titanium dioxide too, that's another of our physical blockers. But a lot of people don't like them because they go on pretty thick, and it takes a lot of effort to get them off. But because they go on thick, and because it takes a lot of effort to get them off, they work really well. You still have to reapply it. It still wears off with sweating and swimming and toweling dry. But when you get those on, they work really, really well. Their formulations have gotten a lot better over the years as well. They go on a little bit silkier, a little bit smoother. It's a little bit easier to get them off. So don't give up on the zinc oxide if you tried it in the past and you hated it. There's a lot of new formulations. People will say, well, what brands do you recommend? I'm not brand loyal. There are so many different brands out there. You find the brand that you like, the name that you like, the price point that you like. It's just a matter of finding the product that you like. It does take some trial and error. Sample what you can. Try the best things out. Try what your friends are offering. But you want to look for something that's a minimum of SPF 30, up to 50. You can go higher, but 30 to 50 is really kind of the sweet spot. Preferably a physical blocker, zinc oxide and titanium dioxide. But I'm also okay if you use the chemical blockers as long as you're using them. So what does that mean and how to use them correctly? Use something that's water resistant or sweat resistant when you're out and about for swimming, golfing, playing tennis, pickleball. Out and about, you want to use something sweat and water resistant. Broad spectrum, meaning it covers UVA and UVB rays. We'll get into that in a second. And reapplying every couple hours. 2 hours at most. You really should be putting stuff back on roughly every 90 minutes. I know it seems like a lot, but it does wear off and you're going to be basically unprotected if you let your sunscreen last for more than 2 hours. I'm another big fan of the sticks. I love the sunscreen sticks. You can just keep it with you. You don't have to get all greasy. You just smear it on anything that's exposed and you go on your way. I hate the sprays. When you see people spraying, usually you see all the mist going out in the air and you can see a little bit landing on you. If you use a spray, I'm not opposed or happy you're using something, but I generally recommend spraying it into your hand and massaging it in wherever you need it to go. So that's my spiel on sprays. If you've got no one else around, you've got to get something on somehow, then use the spray, but try to rub it in if you can. All right, so how else can we prevent skin cancer? So the other thing to think about is being cautious when you're around snow, the sand, the water. You get a lot of reflection of the ultraviolet rays, so it is important to continue to keep yourself protected. Even on these cold days, if you're out skiing or you're out shoveling snow, you definitely want to get that sunscreen on. Vitamin D is so important. We know that it comes from being exposed to the sun, but for a lot of you guys in this room, sun exposure is not going to be your best way to get the vitamin D. So it's important to make sure you're getting enough vitamin D through your dietary sources or supplements. But sometimes people say, oh, go out and get some sunlight. It's good for you. Get your vitamin D. Especially for melanoma survivors or relatives of those with melanoma or history of skin cancer, we do advocate that you get your vitamin D from supplements or dietary sources. And please, by all means, avoid tanning beds. There's zero thing as such a thing as safe tan. If there's no such thing as a base tan, the second your skin starts to turn color, you are getting damage to your DNA. It is a sign that there is damage happening in your bodies in the repair process. The more damage you get, the more likelihood you are to get skin cancer. So tanning beds are this heavy concentration of sun exposure all at once. It's not safe. It will definitely increase your risk of melanoma, basal cells, squamous cells. Yes, occasionally in dermatology we use a very concentrated set specific narrowband UVB treatments for certain diseases. We're very careful with that. They're more or less glorified medical tanning beds, but that's it. I do not want people out in tanning beds. If you have in your house, get rid of them. There should be no tanning beds anywhere available for public consumption. Okay, someone needs to feel a tanning bed. Do I like tanning beds? I hate tanning beds. Okay. All right, so the other ways that the sun affects your skin is not just through causing skin cancer, but it can also cause aging, so fine lines, wrinkles, brown spots, sunspots, and of course we know that it burns. So there's two main types of ultraviolet light, A and B. A causes aging for the most part, and B causes burning. So you really want to have that broad spectrum sunscreen or those sun protective coatings that's going to protect you from all types of light. And here's just a bit of an example of the early changes that we can see. So this is a young patient at 17, and you can already see that she's starting to develop sun nam edge, so without the special light that we use. And then as you move along, you can see some of those marks that she has. And then we see a patient roughly in their 60s, and you can see all the damage that's already accumulated in that far picture. So damage starts early. The sooner you start protecting your skin, the better off you're going to be. All right, so as I've kind of alluded to, there is no safe way to tan. Okay, so sun is going to cause sunburn immediately. Continued exposure to the sun, you'll start to see those age spots, which no one really likes. You'll start to see wrinkles. So these are kind of the more general things that no one really likes. And of course, the worst part of this is the development of skin cancer. So as much as we love the sun, as much as it's great to see this beautiful sunny day, I am not advocating for avoiding the sun. I'm just advocating for protecting yourself from the sun and enjoying safe sun. So that's my public service announcement. And I think that's all I have there. So, sponsored by the American Foundry of Just thank you all for being here. Thank you for inviting me. And it's great to see some familiar faces. I'm so happy you're all here. So listen to me talk more. No, I think I'll buy any of fun.
Thank you so much, Cindy. Thank you so much, Cynthia. You know, we always learn, and this is the time of year where we need to be mindful of all of this. I did want to introduce just a couple other people. First of all, Katie Baglini organized every end of Katie's in here outside, but she put all of this together, so I want to recognize her. And we have some amazing nurse leaders. We have Melissa Kratz as our Director of Quality, and hiding behind her, Carrie Kluska, who's our MSK quality nurse. And then we have some of our young, we have 9 doctors training to be oncologists at LDHM. These are, I believe 4 of the 9 are here tonight. They're up against, I saw Natalie Finn Johnson up there too. So, Yes, overall, the field is facing a shortage of properly trained oncologists to be the next generation. So we're very lucky. Actually, in a month, we're going to have graduation of our 15th, 16th, and 17th fellows, and 2 of them are continuing to stay on here. So I'd like to introduce Dr. Aaron Blackham. Aaron's, I think so many of you know him from the OR, from our MDCs. We've been very, very lucky to have Aaron join the melanoma program. It's been quite a while. He trained at Moffitt Cancer Center, which is one of the elite training centers. And Aaron, how many, if people are comfortable, just raise your hand, how many of you have had TVEC injections by this man? And so this is a Lehigh Valley original. Aaron's going to really talk about how we took something that's FDA approved for stage 3 melanoma, and starting with Paul, who's become famous in this article, the QR codes. It's a revolutionary new treatment that can actually cure. We feel pretty confident with Paul's case and many others following him, can cure patients who are resistant to the standard checkpoint medication. So Aaron, thank you.
Well, it's great to be here. It's good to see some old friends and familiar faces, and this is why we do these. This is why we became oncologists. This is why we treat cancer. It's to come and celebrate advances and survivorship. And so I'm just proud to be here with all of you, and just congratulate each and every one of you for the journey you've been on. Some of you are continuing that journey. Hopefully there are many of you who have completed that journey. I'm just honored to be here with you, and thank you for having us have this opportunity to celebrate with you. So, like Dr. Nair said, I'm going to just mention a few things about TVEC. I've talked about that before, but it's been a couple of years, and I won't be talking about surgery, no gross pictures today. TVEC is a genetically modified herpes simplex virus, which is the virus that causes cold sores. But it's genetically modified to selectively infect and destroy cancer cells, specifically melanoma. And in order to be effective, it's injected directly into a tumor. So a lymph node or a spot on the skin or some tumor, it has to be directly injected into it. And the effects of TVEC really are twofold. One, there's a direct effect on that tumor where the virus is injected. The virus infects those melanoma cells and kills those cells. And as those cells are killed, it produces what are called antigens, or tumor-specific antigens. Those antigens can then be recognized by the immune system, and the immune system will then go out to other parts of the body looking for the same antigens on melanoma sites of the melanoma cells and other sites of the body. So there's a local effect, and then there's the systemic effect. So this is the original clinical paper that came out back in 2014 or 15, so it's been around for 7 or 8 years. But they looked at just melanoma that came back in the skin, called in transit melanoma. Some of you are familiar with that. And melanoma that recurs in lymph nodes. So they studied this treatment in those type of patients. And these patients, this was before immunotherapy was widely available. And so this was given just TVEC alone. And this trial showed that there was a 26% response rate. So 1 out of 4 patients would respond to TVEC. The injected tumors would respond. and 11% would completely respond. And then probably for Dr. Nair and myself and those who treat advanced melanoma, probably the most exciting part about this trial was that they found that 15% of melanoma lesions, melanoma tumors that were injected were actually responded. And so this was kind of proof in concept that there was a systemic effect to this localized treatment. And this is a picture that was part of that trial. All of those dark spots on the picture on the left is melanoma, both that's in transit disease where melanoma comes back in the skin like that. And then on the right side, that's after treatment. That's completely complete response. All of those sites are just pigment. It's not active tumor. So again, pretty remarkable responses in a fair amount of patients. So once TVEC became FDA approved and we started using it, there was a lot of interest to see how we could take advantage of that systemic effect and how we can use it. So people started using TVEC with immunotherapy. So everyone knows about Pevro and Nivo and Ipi. They would start combining TVEC with those systemic medications. And the nice thing about that strategy is TVEC has very few side effects. You have to get the injection, so it's a needle stick, and some people get some pain there. Some people will get flu-like symptoms for a few days, but that's generally it. You don't get the autoimmune side effects like the rash or the colitis or all those other things. And so the idea was if we could use this in combination with immunotherapy, maybe we could get synergistic effect for the immune system with less overall side effects. And so there are a lot of phase 1 and phase 2 trials that show that. And especially with Ipi, I think, as Dr. Nair and I have had a lot of success, probably the most success combining TVEC with Ipi. There was a clinical trial that did show no progression-free survival or overall survival when it was used with Pembro. But like I said, a lot of phase 2 and phase 1 and phase 2 data shows response, and the phase 3 trial with Ipi, phase 2 trial with Ipi showed that it did have a higher response rate. So there's also been people who started looking at neoadjuvant TVEC. Neoadjuvant means that you treat a tumor with, in this case, TVEC, prior to having surgery. And we've done this for some people and some of the patients. And then the last thing there, there have been people who started using TVEC after progression. So after being on a lot of different trials, kind of exhausting everything else, and then using TVEC and as kind of a rescue last ditch effort almost. Is that me? So this is the paper that Dr. Nair mentioned. This was published last year. This was a case report that is our first patient, first experience with TVEC at Lehigh Valley. And Paul is here with us today, and just appreciate him and his determination over the years to fight this disease, and we just are so grateful for him. But just to review his story, he was diagnosed with stage 1 melanoma in 2012. And then starting in 2013, started having multiple recurrences. He was treated with everything available, and as new treatments became available, he would get these treatments. He even was on a trial with a vaccine. And then I think in 2017, He developed over 30 different in-transit or metastatic cutaneous lesions all over his skin. And it was that time that he came to Lehigh Valley. We're working on it too bad. Sorry. Any suggestions? All right, I'll speak really loud. If you can't hear me, and Mark in the back, raise your hand. All right, so at this point, we treated some of these tumors with TVEC. He had an active tumor on his adrenal gland that we gave radiation to, and that was followed by IFI, Yervoy. And he had a remarkable response. And again, lots of treatment beforehand, and we were able to get a complete response. This is pictures from that publication. You can see all those dark spots on his skin were all little tumors of melanoma. And after getting treatment, you can see this white halo around each of these spots, signifying the immune system targeting the pigment in that area. And we ended up biopsying a bunch of these areas to prove that they were all completely treated. And then over the years, these have slowly faded. And he's now about 5 years out from this treatment, and has had no other treatment and is disease-free. So that kind of started our journey at Lehigh Valley with TVEC. And since that time, we've treated 35 patients with advanced melanoma with TVEC. We've used TVEC for a couple other cancers, but mostly for melanoma. And again, some of you are here today. And again, the beginnings of TVEC was all for stage 3 disease, with the in-transit disease or lymph nodes. But we started using it in patients who were stage 4, and use it in a combination with other treatments, trying to boost the immune system, to give the immune system more energy to go out and fight the melanoma. And out of all these 35 patients, each patient's journey has been different. Every treatment's been individualized. It's all been a little different. The sequence of events, the sequence of treatments, all been different. But as much as we can, when we feel like TVEC is something to be introduced into that treatment plan, we've done it. Sometimes we do it with immunotherapy. Sometimes we do it with radiation. Sometimes we do IFI after. The sequence is all different, so it's very individualized. But like I said, in a lot of these patients, they've had a lot of treatment beforehand. So out of those 35 patients, Lehigh Valley, at least 15 or 16 have had a complete response and have no evidence of disease as of today. Many of these patients, and several others, still have cancer, but they're doing much better than expected, and have stable disease, and they're still living functional lives. Many of these patients have very aggressive mutations. We've seen a lot of these patients have had the most feared mutations of melanoma, like BRAF and NRAS. We've been able to get them to get responses in those patients. And as I said, many of these patients, we've started this strategy after sometimes years of other treatment, and were considered treatment refractory and kind of at the end of the line. And we did one kind of last-ditch effort to boost the immune system, reignite everything, throw the kitchen sink at it, and we're able to get responses. So again, I don't want you to walk away thinking TVEC is the all, be-all wonder drug. It's just one part in this strategy. Of these 35 patients and the ones who've had really great responses. And some of those patients, they've only had 1 or 2 doses of TVEC, and TVEC may have just played kind of a supportive role. In other patients, they got 6, 8, 9 treatments of TVEC, and it probably played a more significant role. So again, don't walk away thinking this is the be-all, but it's part of a strategy that's we're finding success with. And this is my last slide. So again, this is not a strategy that's used very often. It is not widely used. This is a publication that just came out last year, and this is a multi-institutional study. There were 11 cancer institutions part of the study, and they recruited 112 patients. Now, those 112 patients were much like the patients I've described. A lot of them were treatment refractory, and these institutions were using some of the same strategies that we've been using and what I've described. They did not seem to at least mention the use of radiation, which we've been doing with these kind of strategies. But this particular publication reported 37% complete response rate in field, meaning the lesions that were treated. That's not systemic complete response rate. So it's a little different than the data that I was just saying, that the patients are patients who had complete response. But the main reason I wanted to show this, to describe this publication, was to show you these curves. So this curve right here, this green curve, are patients in this series, of these 112 patients who had a complete response. That their target lesions that got treated with TVEC and then with all this other treatment, when they had a complete response, this is their survival. And about 75–80% of them, that curve flattens out, and it goes out to 5 years. And it's just remarkable, and that's what we're seeing. The patients who have a good response to the strategy, their response is durable, and we're seeing cures, which is just phenomenal. So, for those who have had TVEC, thank you for being a part of our journey, and again, thank Dr. Nair for his vision, and we'll just continue to push this field forward and do everything we can to get the best outcomes for you and your families and everyone who has to deal with this disease. Happy to take any questions. Yeah.
How long have you been working with TVEC?
At Moffitt, we started doing some when I was in training there. That was 8–9 years ago when TVEC first came out. I treated a couple patients with TVEC there, and then we've had these 35 patients here over the last 6 years. So, all right, thank you guys.
Thank you so much, Aaron. Aaron's such a phenomenal partner. And Paul, would you mind just standing up, because Paul is the first one that really kind of, there he is, Paul. It was around 5 years ago now, and it was a really gutsy event because he had been exposed to all the medicines. And Aaron and I, we actually had a video call. I remember Melissa standing there with his mentor from Moffitt. We were so fortunate that Aaron came here from Moffitt with all this experience, and it wasn't approved for use in stage 4. We were able to get it approved, and we debated, was it the right thing to do that or not? And we actually had our peers at Moffitt said, we've nothing to lose, give it a try. Paul was willing to try. And we've learned so much over the last 5 years. And as Aaron said, this really in use in stage 4 is a Lehigh Valley original. All the publications are really in stage 3. And we've now become, because recently, now that we've figured out giving stereotactic radiation, which is usually 3 to 5 doses And I don't think Allison McIntosh, she was trying to get here. She was taking care of her 2 kids. She's an awesome part of our team. Allison is one of the smartest and most amazing radiation oncologists, and she's part of our team. And so she was part of Pulse Care. And so sometimes, it's serendipity, you kind of see this. And so now since then, 6 out of 12 of the patients that have had, I often refer to Paul's treatment, just give me a chance, have actually in stage 4, have had durable remissions. I think in a couple more years, we may actually have 6 cures. This is after, right now our main treatments, the combination checkpoint or the BRAF/MEK can cure about 40–50% of patients, but the other half, nobody really knows in the US what to do. We think we can potentially get long durations of remission in the other half, and so we're planning to now do this as a prospective study, and we may be, thanks to our survivor community, may be part of changing all this for the better. And now I'd like to introduce a very important member of our team. Erin Levin is a registered dietitian. We all know that our diet is very important to our gut health, our microbiome. Starting maybe 10 years ago, some of my patients joked with me, do you have stock in Costco? Because I started talking about going to Costco, getting a big tub of mixed nuts and eating a handful 3 times a week to improve the microbiome. And Erin would come to me, where are you getting all this? Because she's very evidence-based. But she's going to really talk to us about diet and fighting melanoma.
Am I using this?
Yep.
Hello. I don't think I could talk like that though. All right, you can hear me? Yeah. There's no crackling. Okay, perfect. All right, well, thank you so much. It's great to be here. I really enjoyed meeting a lot of you at my little table out here earlier. I was really surprised. Some of you said you were like most excited for my talk. Yeah. So I hope I deliver. No pressure. But yeah, I've been with the network. I've been at the Cancer Center for about 12 years. And so I just work specifically with cancer patients. It's really, my passion, and I love being here and hearing all your stories. So those of you that I spoke to that wanted to, see a dietitian, I hope I see you again, one-on-one. So yes, we talk a lot about evidence-based research here. And we want to make sure we're only teaching things that are evidence-based, but studying nutrition is really hard, mainly because randomizing participants is not really practical. We can't force people to eat one way unless we're keeping them in a feeding lab and giving them the same food all the time. We can do that. Some studies do that, but they're really short studies. So it's hard to get long-term studies of people eating one way. So we have to kind of rely on what's called observational studies. There's people reporting, relying on food surveys. So I don't know about you, but I don't always remember like what I ate for dinner yesterday, or if I had a snack between lunch and breakfast yesterday. So that's how a lot of these studies are. It's really relying on, remembering what you ate and how much you ate of things. Also, food is complicated. So you have one food like chicken. Well, there's all kinds, like was it the breast or the thigh, the skin on, skin off, was it baked or broiled? So there's all these different kinds of food, even though it's one food. And people are complicated. There's different, we all are different, ages, sex, different weights, and in the case of melanoma, different sun exposures too. And then remembering that people aren't animals, so studies done on animals don't always translate to humans, so we have to keep that in mind as well. So it's hard to do a lot of really good nutrition studies, but kind of have to work with what we have. And we also have to remember that journalists are trained research scientists. So things we hear on the news,
are often kind of over-exaggerated, or it might just be one study. So we have to keep that in mind as well. One study might be the start of something that, more studies are needed to kind of put the pieces of the puzzle together. Okay. So we know that obesity, maybe you do know, maybe you don't, but obesity is linked to many types of cancers, and melanoma is no different. So higher BMI, body surface area, and obesity-related insulin resistance all increase the risk for melanoma. And that was found to be particularly in males in particular. There's a theory on that maybe because females don't spend as much time in the sun. Maybe they're not out exposing their bodies much in the sun. There's also bariatric surgery seem to be protective of melanoma. If anybody has had post-bariatric surgery. Worse outcomes were noted after resection in those with obesity. And in animal studies and in vitro studies, so like test tube studies, calories restriction showed a reduction in melanoma progression. So reducing your calorie intake in like mice showed a reduction in melanoma progression. But then there was also that obesity paradox where male patients who were overweight and obese and treated with immunotherapy actually did better. So there's kind of that two sides of the coin there. But that was not the case in those that were treated with chemotherapy. So there are two specific dietary patterns that when followed very closely were associated with lower risk of melanoma. And those two, the first one is the Mediterranean diet. So you've probably heard a little bit about this. It's the diet that's inspired by the eating habits of the region of the Mediterranean countries like Spain and Italy, Portugal. So it's really rich in vegetables, legumes, whole grains, fruits, cereals, but it has moderate to low amounts of fish, meat, dairy products, added sugars, and alcohol with meals, wine specifically. And the second dietary pattern is called the DASH diet. It stands for Dietary Approaches to Stop Hypertension. It was designed initially to help lower blood pressure. So it's a fairly similar diet where it has a lot of whole grains, fruits, vegetables. Slightly different part of it is that it includes some low-fat dairy products. That makes it a little bit different than the Mediterranean diet. So both of these diets were found to be especially helpful in preventing melanoma in women under the age of 50 in particular. So kind of like obesity, alcohol increases risk for many cancers, as well as melanoma. So we found there's been a 20% increased risk in melanoma in those who drink versus those who don't drink or only drink occasionally. And the more you drink, the higher the risk. So 55% increased risk for 50 grams of ethanol a day, which is about 3.5 drinks. 64% increased risk when you go up to 7 drinks a day. This is a lot of drinks. So interestingly enough, the type of drink matters too. So it was found that especially with white wine in particular, there was an increased correlation there. So I know those of you who have white wine right now are probably not happy with me, but and you're probably wondering why white wine. You don't know for sure. The theory is maybe it may be because it contains more of this acetaldehyde. I can never say that word. And it has less of the antioxidants in it compared to red wine. Might be one of the reasons why white wine in particular. So something to think about. Okay. So this slide shows some of the foods that have been studied over the past few years in relation to melanoma risk, prevention of melanoma in particular. So fruits and vegetables in general were shown to reduce melanoma risk in small studies, but there's not as much in larger studies. In particular, it was found onions, garlic, and legumes were shown to decrease risk, while for some reason cabbage was shown to increase risk. Cereals, sweets, particularly chocolate and candy bars, were shown to increase risk of melanoma. And interestingly enough, red meat and processed meat seem to have a protective effect. And again, this is based on like those surveys of, asking patients what they eat and then following them to see if they develop melanoma. Eggs and olive oil reduced risk, and coffee intake anywhere from 1 to 4 cups a day seemed to reduce risk, but tea really didn't have much. It only showed a protective effect in a small study. So based on this, would I tell you to stop eating cabbage and start eating red meat and processed meat? No, I would not. That's what you have to keep in mind. We know that red meat has other, there's other reasons why we would tell you to limit red meat in general for overall cancer prevention. You want to limit red and processed meats. Cabbage, that just seems really random. Cabbage has benefits. If you don't want to eat cabbage, that's fine too, but just make sure you're eating lots and lots of other vegetables. But yeah, we just need to have more studies to see if some of these things are really worthy of changing, our lifestyle with. But fruits and vegetables, of course, I want you to eat. Eggs are fine, olive oil, coffee, all of these things are great to include in your diet. And of course, it's recommended to not eat a lot of sweets. So everything else is kind of things we'd recommend anyway. Okay. So those were some specific foods studied. So these are going to be some of the nutrients that have been studied. The first one is, it stands for polyunsaturated fatty acids. So these would include fatty acids like omega-3s and omega-6s you may have heard of. So the largest studies show that there's no effect on melanoma risk in how much of these fatty acids you have. But then when they broke it down, it showed that actually there was a reduced risk with just the omega-3 fatty acids, and those are the ones you may have heard of, like they're in salmon and tuna and walnuts and flaxseed oils, so some of those healthy fats, you may have heard of them. Meanwhile, there was an increased risk with the omega-6 fatty acids, which are in more of like corn oil, soybean oil, all your other kind of oils. The next one, another interesting one, is vitamin C. There's a higher melanoma risk with higher intake of foods that have vitamin C and citrus, interestingly. So then on other studies, it showed that it had a protective effect. So it's one of those where there's been studies on both sides, so it's kind of up in the air right now, what you want to do with that. There's studies on both sides of it. Probably wouldn't really change your intake of anything related to vitamin C. Vitamin D, there's been no association found between vitamin D intake and melanoma risk in large studies, but smaller studies showed maybe a small protective effect. But the interesting thing for patients who already have melanoma showed higher vitamin D levels have been associated with thinner tumors and longer survival, while vitamin D deficiency has been associated with advanced melanoma stage. So there's no real consensus on how much vitamin D you should consume, what your levels in your blood should be, but it's been suggested or proposed in the literature for looking for a level of 70 to 100, which is pretty high compared to what's considered normal. So it's really the high end of normal. If you get your vitamin D level checked in your lab work, that would really be aiming for like the high end of normal. The next one is vitamin A, which showed there was a reduced risk with high intake of just one certain kind of vitamin A, which is retinol. It's kind of like the preformed vitamin A, but no other forms of vitamin A. Vitamin E showed, lots of studies were done, but showed no effect on melanoma risk. And vitamin B, kind of like vitamin C, there's been a lot of studies, but really there's no conclusion. It kind of remains very controversial. So there's a lot of studies out there. Some have some good evidence, some we're still a little confused about. But we have to remember that we eat, I mentioned a lot of vitamins and nutrients, but we have to remember that we eat food, not nutrients. So we don't have like a plate of vitamin D and a side of retinol. We eat food. So we want to remember that diet matters, quality of diet matters, and there was a study on that as well that showed people with better diet quality in the year leading to their melanoma diagnosis were less likely to present with fit melanomas than those whose diet was poor quality. And in that study, they defined diet quality as having seafood, plant proteins, low sodium, low saturated fat, and green vegetables. Specifically, those patients ate fruit every day and did not eat red meat every day. So, contrary to what I said before about red meat being protected, this study showed that it was, a good thing to not eat red meat. Okay. So kind of changing gears here, that was mostly about prevention. But what about during treatment? If you have the unfortunate diagnosis of melanoma and you need to get treatment, and you're offered treatment with immunotherapy, this is something you'll want to listen to. So Dr. Nair mentioned this a little bit. So one of the biggest recent breakthroughs in terms of diet and nutrition and melanoma is that it was found that those who had a more diverse microbiome in their gut responding more favorably to their immunotherapy than those who had a lower microbiome diversity. So what is the microbiome, you might be wondering? It's a community of microorganisms such as bacteria, fungi, and viruses that inhabit a particular environment, and especially the collection of microorganisms living in or on the human body. So they inhabit many areas in our body, not just the gut. And they outnumber human cells, trillions of microorganisms and thousands of different species. So research is exploring how the microbiome may enhance the effectiveness of immunotherapy. The specific interest point is the ability of the gut microbiota to overcome resistance to immune checkpoint inhibitors. So simply put, the better your microbiome is, the stronger your immune system, the better effect from your immunotherapy. So then, how do we support our gut microbiome through our diet? Oops, I think I had one more. So the answer is fiber. We've known for a long time the many, many benefits of fiber. It's good for digestive health, heart health, diabetes. It's good for so many things. But patients who ate a high fiber diet were 5 times more likely to respond to their immunotherapy. So fiber, in case you're not sure what it is. It's the non-digestible part of a plant. So you do not get fiber from animal sources. So there's no fiber in meat or dairy, things like that. So it's just found in plant foods. We get it from fruits, vegetables, whole grains, legumes, nuts, seeds, all of that good stuff. Occasionally you might find some fiber added to some processed products, but naturally we get it from these plant foods. And the more variety we have in our diet, the more diverse our microbiome is. So if you're only eating like the same 2 or 3 vegetables or fruits every day, I mean, I'm glad you're eating some, but it's great if you could get a wide variety of colorful fruits and vegetables every day, then you're gonna get all the benefits of a wide variety of phytochemicals and make your microbiome even more diverse. So how do you reach your fiber goals? Those 2 diets I mentioned earlier, the Mediterranean diet and the DASH diet, are both great ways to do that because they put a lot of emphasis on fruits and vegetables and whole grains. But this is just a visual way to show you. It's just what, 7 foods there that can get you up to the recommended 25 grams a day. So oatmeal, beans, broccoli, berries, nuts, a pear, a slice of bread. And think about too how you might eat these foods together. You might eat the oatmeal with the nuts on top and the berries on top. So that's like 1 meal right there and you have 10 grams. So it's easy, but I know it's hard at the same time. It takes a lot of planning and thinking it through and making sure you have those things available to you, keeping produce in the house and going shopping regularly. So it is hard and easy at the same time. I recognize that for sure. So you might be thinking, maybe some of you take probiotics, supplements, and you may be wondering, maybe that's a good way to increase your microbiome diversity. And in that study, they did look at that as well, and it actually shows that people who took probiotics, they actually had lower gut microbiome diversity, which was really interesting. Yeah, the people are surprised. I was surprised too. So definitely something to think about if you're taking probiotics, if that's something you want to continue. But the point is, you know, you can get these things through food. That's really the best way to do it.
No.
Okay. So, kind of the bottom line is an ideal diet for melanoma, both prevention and treatment, is a diet that's high in plant foods and low in alcohol. And of course, striving to maintain a healthy weight is always an important thing as well. So LVHM cancer support dietitians are available to you to help you kind of figure it all out. We take into account, when we meet up with you one-on-one, we can take into account, you know, other medical conditions you have, your food preferences, if you really like hate certain things or if you're allergic to things. We'll kind of help you pull it all together and come up with something that will work for you. We don't love just like taking foods away from you. We really want to, I try to focus on adding things to your diet first, not just taking away. Because there's lots of things that you probably could eat more of rather than eat less of. So definitely, if we haven't met before, I have information, I'll have my contact information on the next slide too. But we have dietitians at every one of our cancer center sites at Lehigh Valley. So there's a dietitian available wherever you live. And then I just have a couple of resources up here that I like in particular to kind of help you out in the meantime. 2 websites, if you can see them, AICR.org and cookforyourlife.org, and then 2 cookbooks, all of which have great nutrition information and really focused on plant-forward recipes and information there. And I think that's it. Woo!
Any some questions for
That's it.
Talk along with vitamin B's and mineral
in cocoa? Yeah.
Are there any supplements? Well, we may suggest.
Yeah, so that's a good question. I'm always going to be like pro food, like try and get all your nutrients from food first. Probably, the main thing, the one that's the hardest to get from food, and also because, like we heard already tonight, to limit your sun exposure is going to be vitamin D. Supplements are usually going to be the biggest recommendation that I'll have. It's very hard to get vitamin D from food. It's in like very few things, unless you're drinking a lot of milk, which most people aren't, or eating, certain kinds of fish or mushrooms, and eating a lot of those things. It's really hard to get in your vitamin D.
And I've recently they take all of pneumatic for your rocks.
Well, and with that, I don't have a general recommendation for that. I always look at a patient, what else they're taking, what else they're on, because a lot of herbal supplements can have interactions, and that's kind of the main thing that we're looking for, making sure it doesn't interact with anything else that you're on. But I know turmeric is used a lot by patients, kind of like an anti-inflammatory. I don't know if that's why you're taking it, but that's what a lot of patients will be taking it for. Cure I'm pro putting it like on your food, like in curries and stuff. I think that's, I'm always the first kind of a recommendation. I get a little nervous when it's like, when you take it in a supplement form, it's like a high concentrated amount, so you want to make sure it's not interacting with anything else that you might be taking. Sure.
But there. Yep.
Okay.
What are your thoughts on about fish in terms of like the benefits the omega-3 versus the environmental intake that fish?
Oh.
Let's repeat the question.
Yeah, so the question was about fish and kind of like weighing like the benefits of getting the omega-3s, and then also like the environmental impact of that. Yeah, I mean, I might not know all the exact species that are, but the ones that are the right ones to pick, but there are lists of that you can find online. I don't know them off the top of my head, but where you can find, the ones that are both high in omega-3s, but are on like the, safe to, I'm blanking on the word. Consume. Safe to consume, yeah. Off the top of my head, I don't know that, but I think it's the, I can't remember the website. There's a website that's like about fishing that has that information.
This question that
I'm going to put a lot of these aware of it. The cheese was. I wanted to say I was green vegan, but maybe they're good for anything, but I mean, must be turkeys in what where the situation is. Like I'm going to say, just if I knew with it was good as things, but that's makes you with the stuff without.
Right.
So you can't always say,
That's what makes it hard.
we said that this is in front of the person and maybe, like, only take 12 years, and I swear by it.
Yeah.
It's the thing that,
Yeah. That's what definitely makes it hard, because things could be good for one thing and then maybe not for another.
and I'm in North Dakota, like, the people want to wait in.
Yeah.
Indeed,
Yeah. I know. I appreciate that comment. Yeah, it is difficult to know. And you might not know the answer. But again, what we can offer, you know, our services, what we do with patients is have them fill out like a food diary of what they're eating for a few days, and we run it through our computer program that shows all of the nutrients that they're getting in, vitamins, minerals, in addition to like their calories and protein and all of that. We do that as a way to kind of see, like, do you need to be taking all of these things? Are you getting in enough through your diet? You know, do you need this extra supplementation? If you're already getting in plenty of vitamin C, do you need to be taking in additional vitamin C? That type of thing. So it's kind of the best way to know.
Like people tell us is they eat out of the right vitamins, like the person.
Yes, vitamin levels can be checked. Some are more routinely checked than others. Some are not checked routinely, and therefore can cost a lot of money to be checked. Like, it's pretty standard to get like vitamin D checked these days, and like some of your B vitamins, but like vitamin C, I don't ever see that checked. Like, you know what I mean? That's not a common lab that gets checked. But some of the other like minerals don't get checked very often. So, right, against like expensive because they're not, routine. So yeah, it's like we don't really know, but we can kind of know based on, you know, if you do an analysis of your diet.
Maybe we will take one last question, and Erin will be available for more questions. Yeah.
It's not a question. I just want to offer a word of advice. I'm a nurse. Just remember, vitamins are really important, and you just have to include them on your list of medications, just as if it was a medication, because they will interact with your meds. So it's really important that you're letting the doctor know. So don't forget about them when you're telling your doctor what medications they're on. Because I've seen some pretty bad interactions. And when I hear clear, it makes me shiver because it will interact with anticoagulants. I've seen that bleeding problems and things like that. So I just want to offer them advice. Treat them just like medications.
Yes, I second that. Because that's a question I was asked, like, are you taking anything that's not on your medication list? Vitamins, herbal supplements, and a lot of times, yes, people are. I'm like, you need to make sure your doctor knows and you need it on your list so that everyone can see it. Yeah, so thank you for that.
Thank you, Erin. I just want to thank, first of all the survivors, the caregivers, the family members, our staff, everybody that came out. You know, I think we haven't had a live celebration in 4 years. I want to just give an ovation to all the survivors that are here. I know it's more than 50 that are here. I'd like to thank our speakers, Dr. Blackham, Dr. Barnes, Erin. That's the amount of questions show the amount of interest in your topic, and she really covered a controversial area. I hope I don't get in trouble with Morgan, but I'm going to give a little kind of a glimpse into some of the cool things that we're going to be working towards this next year. Yeah, we're not going to sit with curing half of stage 4 or even if we get it over 60%. We're going to continue this quest, and we have a great partnership with Memorial Sloan Kettering, and Mike Postow is one of the leaders there. And Morgan, we have some work to do to get this activated, but we're looking into a vaccine which is from Norway, which is looking promising, which Sloan Kettering and Lehigh Valley are going to test along with immunotherapy in stage 4 melanoma. Some of the, you never know in research if the initial study, it was a very small study in Norway, but they were getting remission rates as high as 80%, 90% in certain things. And vaccines are a real hot area. For 30, 40 years, it's been the holy grail, and vaccines have not really worked in cancer other than in prevention, like HPV vaccine. And many of you probably heard before Christmas, Merck and Moderna partnered on a stage 3 personalized melanoma vaccine. They used the same mRNA technology that's used for COVID vaccine, but instead of changing it for the strain, they basically looked at 34 different proteins and DNA specific, from the mutation testing. And so that's now going to phase 3 testing starting the end of the year. And if that's successful in the future, we'll be giving immunotherapy with a personalized vaccine. But Sloan Kettering is working on a pancreatic cancer vaccine. They've already in the phase 1 seen some promise, and we'll be up there in October. So there's a lot of really cool things. Our survivor community have been very active in clinical trials. Some of you were involved in the trials that saved President Carter's life, before, so that, so we owe a lot to our patients and our survivors for continuing to elevate the field, and we just want to keep celebrating these successes. And I hope you made some new friends tonight. I think there's a lot in common with these tables. So thank you everyone for coming out, and hope I didn't forget anything.